Your body is protected and supported by a framework of bone called your skeleton. Your bones are very strong. They have three main parts: compact bone on the outside, spongy bone on the inside, and bone marrow right at the center. Your bones also have a nerve and blood supply. The structure of bone makes it very tough. A bone will only break if it's put under a lot of force or twisted awkwardly. A broken bone is said to be fractured. Fractures are painful because bone has a nerve and blood supply. If you trip, you usually break your fall by outstretching your hands. This puts a lot of pressure on the wrist bone, which may cause it to fracture. Here we show the forces that are acting on the wrist bone when it hits the ground to break your fall. There are many different types of fractures. A common type is a fracture of the wrist, called a Colles fracture. This type is usually caused by tripping over with the arms stretched out to break a fall. Here we show what the broken bone looks like in a Colles fracture. The two edges of the bone have moved out of line. Colles fractures are most common in women over 50. People who have weakened bones due to osteoporosis are more likely to break their wrist when they fall. Once the wrist bone has been fractured, it may be out of line. If this isn't corrected, the wrist will heal in the wrong position. If the two pieces of bone have been displaced, they need to be repositioned so that they are lined up correctly. This is known as reduction. This can be achieved by pulling on the hand, then manipulating the wrist and hand. The bone is now lined up, so it will heal in the same shape as before the fracture. Your doctor will put a plaster cast around your arm to fix it in the correct position and support the bone while it's healing. This is the end of the animation. Click on the animation screen to watch it again.
The fracture fragments of the distal radius are reduced, and the volar distal radius plate is applied to the bone over the fracture site. The peak aiming guide is secured to the plate with the set screw. Next, the 3.5 mm non-locking screw is placed into the slotted hole of the shaft for temporary fixation. K-wire holes in the distal aspect of the plate accept 1.35 mm K-wires, which can be used to assess distal proximal placement of the plate. If the K-wires are proximal to the joint surface, then all fixed angle screws will be proximal to the joint surface as well. Once plate placement is properly achieved and verified under fluoroscopy, the drop-in drill guide is placed into the peak aiming guide, and the 1.7 mm calibrated drill bit is drilled through the second cortex. The depth measurement can be read off the drill bit itself, or the depth probe can be used. A 2.4 mm locking, non-locking, or near cortex screw is inserted. These steps are repeated to fill the remaining head holes. The remaining 3.5 mm locking screws are placed, and the final construct is evaluated under fluoroscopy for satisfactory reduction. Various aiming guide options are available in the set, including individual drill sleeves, threaded drill guides, and a variable angle drill guide, which can be used according to surgeon preference.